Good morning and welcome to the Health Gorilla TreeTop podcast. My name is Stephen Lane. I am the Chief Medical Officer at Health Gorilla and a practicing family physician and clinical informaticist. And I'm here with my good friend, Hannah Galvin, who is also a clinical informaticist, in her case, coming from the clinical discipline of pediatrics. Hannah and I have had a chance to work together on a number of initiatives over the past few years. She is clearly an innovative and strategic clinical informatics leader, and she's very focused in the area of privacy, bringing to that her perspective as a pediatrician with a really rich clinical background. So, Hannah, thank you so much for joining me today.
I'm happy to be here. It's great to see you.
Yes, indeed. I love doing these podcasts because it's like you and I could do this over a cup of coffee or a glass of wine, but we get to do it here and share it with an audience, and that's an extra treat. So Hannah guides a number of national work groups and serves as an advisor to the ONC, the Office of the National Coordinator for Health IT at the national level. Has also worked with health IT vendors, focusing primarily on the complex issues of privacy and really how to support the continuum of care. We Americans, adults, children have a complex journey that we traverse as we receive our health care, often involving multiple providers in different care settings. Sometimes that is by intention because of a desire to maintain privacy, and sometimes that is simply because of what happens to us in our lives. So this January, earlier this year, Hannah joined me as a member of the ONC's Health IT Advisory Committee and really brought a fresh perspective to that group. We are currently serving together on the HTI-1 proposed rule task force. So this is the task force that the ONC put together to really dig into and provide feedback on their new health data technology and interoperability notice of proposed rulemaking, which is certainly a mouthful. But this is really designed to advance health IT, nationwide interoperability, and we'll dig into that in a little bit. So since 2020, the past couple of years, Hannah has served as the Chief Medical Information Officer for the Cambridge Health Alliance, and I think you're there in the Boston area this morning.
That's right.
Hannah's been in Boston for a while, I gather, having graduated from Wellesley and Harvard Medical School. Did you do your specialty training there at Harvard also?
I did, Boston Children's Hospital.
So you and I are similar in that I had a similar experience at the University of California, where I've done everything there and been a part of that community since I was 17 years old. So it's kind of interesting. Well, let's start off, Hannah, by talking about how you got into this. Here you are, a pediatrician, Boston born and bred, and why health IT? Why informatics? What was the path that led you to your current roles?
Yeah, well, I think, at its heart, ultimately what inspires me at a high level is providing exceptional care to all individuals, even and perhaps especially those who may have been historically marginalized or not have had a voice at the table. And that's been a pretty consistent theme throughout my career and what led me to pediatrics initially, with a focus on child abuse medicine, caring for some of the most vulnerable. And that's where I trained and what I trained to do and planned to do initially. It led me to my first role out of training as a hospitalist and a child abuse physician. And that was actually during the time of meaningful use. And I was pretty tech savvy. I had worked my way through college and medical school, doing various technology related work, building websites and help desk type roles. And so I was tapped to assist the organization that I was working for at that time with the first ever epic Big Bang implementation. And I discovered that I just loved it and had a real penchant for looking at things from that sort of systematic perspective. And that informatics really allowed me to do this. as I considered my overall career path at that time, I discovered that I wanted more exposure to this. So a few years later, I spent some time working directly in the vendor space. I worked for Athena Health, leading a team of clinicians to provide insights to R&D, which allowed me to understand software development from inception to delivery. It also allowed me to speak with operational leaders across the country to understand their goals, their challenges, their pain points. During this time, I continued to practice, initially with a primarily immigrant population and later doing street medicine for homeless and at-risk adolescents. Ultimately, as a physician, serving patients and that sort of goal of providing care to individuals is what continues to drive me. So coming back to healthcare operations was a really good fit. And I spent some time kind of building my chops as an operational leader at Beth Israel Lahey Health. And now I'm in the role as a senior leader at Cambridge Health Alliance, which really kind of fits me like a glove because I'm leveraging innovative technologies to advance the highest quality care for a diverse patient population, which is a population that I really feel called to serve, and is sort of consistent with kind of my career path throughout. Over the past decade or so, I've also been able to build up my network and my portfolio to gradually advance work on the national stage as well, that I know you and I will be talking about a little further, related to granular segmentation and promoting patient-driven sharing of health information and equitable interoperability. And this is something that I'm really excited about because it has potential to significantly benefit all of us, and especially those who historically may have been underrepresented in conversations as health IT infrastructure has been developed in this country. And so I think, my entire journey up into this point has really led me to gain insights and be able to speak to this and to build a portfolio that now allows me to do this work well on the national stage.
That's wonderful. I see so many parallels between our paths over the years. It's really exciting. It's also interesting to see how things have shifted. So when I was young, doing homeless healthcare, there weren't a lot of homeless children. There weren't a lot of homeless families. Just at least where I was in San Francisco, that wasn't what was happening. Obviously, that has changed dramatically. So to hear that was where you got into this, it makes so much sense. So before we dive into the privacy issues, I mean, here you are, a chief medical information officer at a prestigious health system, certainly a little bit of a counterpoint to what we've been talking about, street medicine and vulnerable populations, though clearly that's a part of what you're doing there. What have been your challenges as you've moved into this kind of a health system operational role? And what have you found to be kind of the levers that you can pull and the solutions that you've been able to implement there?
Yeah. I think like everywhere, whether you're at a safety net system like CHA, which is an academic public health system, a safety net system, though also academic and part of the Harvard system, right? Or at a much larger, more well-funded system, there are fiscal challenges everywhere right now. And I think, our particular system, right, we receive a significant portion of our revenue from the Mass Health Waiver, which helps to offset the low fee-for-service payments that we receive from public payers. We have about 75% of our population receives their or is under sort of public payers, and we also have significant reporting requirements under sort of that program and our ACO program and commercial payers. And so, like everywhere, we need to do more with less, right? And I think that's not specific to my health system. I think everywhere is feeling that right now, and it's not a health system problem. I think the vendors are feeling that right now. I think I think the ancillary systems are feeling that right now. I think the payers are feeling that right now. I think one thing I should note in particular is that I am, in addition to sort of the typical kind of CMIO role as the senior clinical informatics leader for the organization, I'm also directly responsible for a number of the IT teams overseeing about 75 of our clinical applications. So I have a pretty broad role in that regard. And one of the big challenges of my job, and something that I really enjoy doing as well, is thinking through how we can align seemingly disparate processes, how to create strategic frameworks that allow for leaner methodologies and leveraging technology in innovative ways to do this. Like in many organizations, we have a matrix governance model, and far too many needs and requests coming in than could ever be completed. And I think everybody feels that way right now. So I have developed new governance structures, executive project management strategy around this, leveraging agile methodologies and some leadership tools that I stole from the Obama White House in order to create some leaner processes, allowing us to do more with less, which is particularly helpful in this fiscal environment. And I think those are things that health leaders everywhere are struggling with, right? And are challenged with. How do I prioritize, right? When I have 100 projects, right? What do I do first, second, and third? And what sort of falls below the line? And I think those are, challenges that all of us are facing right now, regardless of what part of the industry we're in.
That makes perfect sense. I'm going to go off topic here a little bit. I'm struck by the fact that, we are all, as you say, trying to do more with less. And yet when you look at us as a nation, in a global context, we're ending up getting less and spending more,
Sure. Yeah.
What, if anything, do you do in your work that allows you to look outside of the U.S. healthcare context or outside of healthcare to see where we might have opportunities to actually do better with less, as seems to be done everywhere else around the globe, as opposed to the way we're doing it here?
Yeah. I mean, trying to keep up, as you say, with what other countries are doing. We actually just a few weeks ago met with a group from the NHS to understand what they're doing and what sort of innovations and insights we could offer them, and what innovations and insights they could offer us. Right on the billing side of things, they have so much figured out that we have not, and streamlined that we have not figured out here in this country. And yet there is much that we have figured out in related to interoperability and technology that that they're still figuring out in the UK and in Europe. And so, right, I don't think that sort of one system is necessarily better than the other, but I think having those conversations and understanding what we can learn from one another, and having those open doors of communication is really helpful. And the more we can do that, the more we can grow, and being open to sort of understanding and not being stuck in our one path is really the key there.
That's great. So let's dive a little bit into the privacy issues, because I know that this is near and dear to both of our hearts. You have a unique perspective. You're a pediatrician. You were drawn to the care of particularly vulnerable populations. It's hard to imagine any human being more vulnerable than a child who's being abused and is a victim of abuse. And that really led to, I think, a lot of your perspectives on health data privacy, especially as the data of kids and adolescents really does have special requirements. And as those kids traverse, or young people generally traverse healthcare systems, they often find themselves needing to get really confidential care that still needs to be coordinated back into their overall care. Sometimes needs to be communicated with certain parties, either providers or members of the family or care system, and not others. So talk about that. Talk about those challenges and how that has led you to do the work you're doing specifically in health data privacy.
Yeah, I think we have done a great job in this country over the past 15 years or so around building the pipelines of interoperability, right? We have really stimulated the pervasive adoption of certified EHR technology across the country. We now have almost all hospitals, 96% or so of hospitals and over 80% of ambulatory practices have implemented certified EHRs. And the vast majority of these are engaged in the major interoperability domains. We know that most patients have been offered access to portals, and the majority of those who've been offered access have actually accessed those portals, and there's been a huge jump in that over the course of the pandemic. But I think while there are numerous benefits to being able to share data across the ecosystem, we have to be really thoughtful about some of these really difficult cases, some of which involve historically marginalized populations, which may not have been at the table for some of these conversations around issues that they personally experience, around populations like adolescents who have data that are protected by state law and have data that, as you mentioned, are really nuanced in that some of which may need to be protected from parents or guardians in certain cases, but not in other cases. And all of this may serve a little bit as a canary in a coal mine for other issues and other use cases that may affect larger populations as well. So I'll give some examples, right? For instance, when I was doing street medicine, I frequently had patients who would refuse to go to the emergency room when they needed care because their data preceded them. So if their problem list had a diagnosis of substance use disorder or another potentially stigmatizing condition, their experience was that they would be prejudged and given suboptimal care as a result. I remember one young man who had been literally hit by a truck, like literally truck versus person, and didn't want me to send him to the emergency room. And he said, "Doc, they'll just think that I want drugs and they'll send me away." Individuals who have been treated poorly by the system, whether it's because of a behavioral health condition or some other potentially stigmatizing diagnosis, implicit and explicit bias very much exists. There's been a lot written about this, and bias can exist against race, ethnicity, sexual orientation, gender identity, body size, or something else, right? And their experience of receiving healthcare may differ from many of the people who are writing policy, and I think it's really important for us to think about that when we're developing the technology, or writing the policies that are driving interoperability. And it's not just those, right, who are living at the margins. There was a survey done last year of 1,000 patients, and they found that 92% of them, it was done by an independent survey company, and they found that 92% of patients believe that healthcare privacy is a right. And 75% of those patients expressed concern about the way that their personal health data could be used and protecting that privacy. The majority were concerned about the way that it could be used against them. And that concern was significantly higher in historically marginalized populations like ethnic and sexual minorities. So when it comes to adolescent privacy, this is particularly complex, right? Part of this is due to the fact that, like we said, privacy laws are in place for certain types of data, and these can differ state by state. So it's really challenging for an EHR vendor, for instance, to develop flexible technology that could be easily implemented in support of each state law. It's also really difficult because adolescence is a time of gradual development, and that change is different for everyone. So, right, all 12-year-olds are not the same, and all 17-year-olds aren't the same. And many state laws are written to sort of reflect that and leave some interpretation for the clinician. That's not very helpful when you're trying to develop computable rules and to set standards or policies. So many organizations may say, like, from the age of 12 to 17, patient proxies will not have access to notes or appointments. But as clinicians, we know it's much more nuanced than that, right? A 15-year-old, for a 15-year-old, it may not be appropriate for their parent to have access to their sexual history data, but they may have asthma or epilepsy, for instance, and their parent may need that, information about their appointments to help them get to their subspecialty appointment. For instance, we know that oral contraceptive pills can interact with some anti-epileptic medications. And so does the parent need access to that information if the patient is on anti-epileptic medications, right? It becomes very nuanced, right? And depends very much on the patient's maturity level, right? And what, but state laws may protect just the reproductive health information. A mature 17-year-old may not need or want the parent to have access to any sensitive data on the portal, but a 17-year-old with special healthcare needs may need the parent to have access to all of that information. So this requires not just one rule, but layers and layers of rules. And there have been some organizations that have built those out, but it's taken a lot of resourcing, and other organizations can't necessarily replicate that. There's also a lot of emotion around these issues, and parents generally want to be protective of their kids. We have some data that shows that over 50% of teen portal accounts are inappropriately accessed by guardians. And I think that is generally well-meaning parents and guardians who really want to protect their children. And it shows the difficulty of putting computable rules in place to support this privacy. And even when we may put some of those rules in place in the EHR, the parents and guardians are guarantors for those children anyway. And so the bill ends up going to the payer, except in certain circumstances where patients are treated in like Title X clinics. And so the explanation of benefits ends up going to the guarantor. And so it's difficult to protect the privacy, kind of on the payment end as well. So it's very complex because of that all of the pieces of interoperability, all of the different systems set up, and in the nuance kind of involved.
This is really one of those unintended consequences of the digitization of healthcare and the evolution of interoperability, right? I mean, back when I trained, it was all on paper. You went to the doctor's office and you couldn't get it, you couldn't see it. There was just paternalism run rampant, but it allowed for really bespoke workflows that could address the needs of individuals, but in the opinion of the provider or the organization. And so we know that there's a potential mismatch there, that trying to do this in a way that's consistent, that's equitable, that's computable, puts us in a whole new world. But it's so complicated, as you say. These are not rules that are easy to write.
Exactly. And we're doing it after the fact, I think is part of the issue as well, right? We've put the pipelines in place, and now we're trying to go back and correct it, which, it's great that we put these pipelines in place. We're doing, there's so many benefits to that. But now we're trying to go back and figure out how to correct or address some of these unintended consequences.
So another area that you've given some thought to is maternal health and some of the privacy issues there, which are a little different, right? When you're talking about pregnancy care, the management of maternal health, and how maternal data impacts the child, what's the role of the father, and other caregivers. And you did a panel on this at HIMSS this year, which I found really striking. Do you want to talk about what you see as the key issues in maternal health?
Absolutely. I think one of the reasons that maternal health can serve as a good model from which we consider sort of interoperability challenges is that, most women receive a lot of their prenatal care in one setting, typically an ambulatory setting, and then deliver their baby in a different setting, whatever that setting may be, sometimes an inpatient setting, sometimes a birthing center, or even a home setting. But that necessitates the information pipelines that we've been talking about and data standards to support interoperable exchange. So it's a good model to kind of think about sort of other pieces of interoperability and privacy. And a lot of the data collected and exchanged during the prenatal and interpartum workflows is typically considered sensitive. I should pause and sort of say that sensitive is an entirely subjective term, right? Something that I might consider sensitive may not be considered sensitive by you at all. And in fact, you might be offended if something that I referred to as sensitive, was considered sensitive, right? For instance, like consider gender identity. For one individual, their gender identity might be something that they're still coming to terms with, or they need to keep private from family or friends, even in this day and age, because they might face stigma or even safety concerns related to that information. And for another person, that may be a key definer of who they are. And so it may feel even sort of offensive to them to suggest that would be considered sensitive in any way. Historically, state and federal laws have treated certain types of information as sensitive and typically sort of related to reproductive and sexual health care or genetic disorders, behavioral health, and substance use. For certain people, other information might be particularly sensitive as well, right? If I'm a professional athlete and I have an injury, that could be really sensitive if it got out to the media, that kind of thing. But maternal health data often contains information that we more typically think of as sensitive, like testing for sexually transmitted infections, syphilis or HIV, history of previous pregnancies and terminations, social history, which now includes social determinants, that kind of thing. And so, right, there's a lot of concern about sort of the sharing of that data, right? And so that in many ways is why it can serve as a good model here. So in addition to the data being transferred from the ambulatory setting to whatever setting the mom is going to deliver in, there is also the fact that the child's chart, this new baby's chart, includes a lot of that data as well. As a pediatrician, it's really important for me to understand for the child's health, did mom have a sexually transmitted infection during pregnancy, like HIV, like syphilis, because that impacts how I'm going to care for the baby. It's really important for me to know, is there intimate partner violence in this relationship if I'm going to appropriately care for the baby? But that means that the baby's record now is a new record, and a record of another individual has data that is pertinent to mom. And that also means that the baby's record is accessible to the other parent, whoever that other parent may be, right? It may be an ex-partner, it may be a current partner, right? And that can cause safety issues, frankly, right? If mom reports intimate partner violence, right? And now that's in the baby's record, and the partner, the ex-partner, knows that, or if mom has questions about the baby's paternity, right? And that's in the baby's record. We've already seen at least one case where mom has reported financial insecurity, and the partner received that or read that information in the baby's record and used that information to seek custody and won custody over the baby based on mom's social determinants data in the record. And so there are concerns about that now that you have this shared data in the record. And so I think we have to be really thoughtful about that. And I think those were use cases that we didn't really consider when we sort of went on electronic health records or started sharing this data. Additionally, now that we've been on EHRs for 20, 30, 40 years in some cases, right? There are children who have grown up with a longitudinal record. And so there are 18-year-olds who are getting access to their own data who now have access to mom's data in their newborn record that mom may or may not want that child to know about. Maybe mom doesn't want the child to know about her prior abortion, right? Which may be documented in that record. And so I think we really need to be sort of thoughtful about that and understand that data is being shared and that we need to consider how to manage some of these use cases that previously were not considered.
So being thoughtful and understanding is a great first step, but then we need to really operationalize that, right?
Correct.
I think that comes down to the issues of consent. How do we capture from an individual their preferences regarding what data is accessed, exchanged, used, in what context, by whom, et cetera? And how do we, again, in this digital world, how do we capture that in a way that can then be acted on, that's computable, if you will? And so you've given a lot of thought to consent management, and how to document meaningful consent, how to exchange and leverage this data as people transition their care into different settings, and as you say, as the care itself really transitions, as young people reach the age of majority. How do we do this? I mean, what are the tools that are available for that?
Yeah, definitely. I think, consent is a huge part of it. And then the other part of it is how do we actually segment the data? So if I say I don't want to share my reproductive health data with my optometrist, how can I share all of my other data with my optometrist, but not my reproductive health data? So there are sort of two pieces working in tandem, right? The consent piece, and then the granular segmentation of the data. And my work is focused more specifically on the granular segmentation standards, but they're really closely interwoven. And we need to advance a maturity model that will allow patients to specify their privacy choices, and then the downstream technologies to respect those choices. And there are some groups, specifically the community-based care and privacy work group that are working on FHIR consent, the FHIR consent resource, and Stewards of Change Institute that we're working closely with around sort of bringing together groups to sort of test consent. Consent can mean sort of a number of different but closely related things, right? There's the sort of ethics framework, and then there's sort of the technical piece. From an ethics framework, we can talk about informed consent, right? How an individual can know what they're agreeing to, right? Most of us sort of sign our Apple terms and conditions without reading them. They're written in sort of legalese. And so there's sort of the larger questions of kind of what are the baseline requirements needed of any consent document? So if I am withholding that reproductive health information from my optometrist, do I fully understand the risks and implications of what I'm doing? Do I understand that there are other ways that my optometrist might be able to glean that information from other information in my medical record, right? And so that's sort of all part of consent. What makes a competent individual to be able to give that consent? And the adolescent issue comes up again here, right? If I'm a 15-year-old and I don't want to share my reproductive health data, do the state laws allow me only to withhold that from my parents or guardian, or can I withhold that also from other providers. I don't think, we've really sort of tested that fully, and there are a lot of open questions there. But then there's sort of the technical pieces, right? We have to, so if I indicated my desire to request those restrictions or those privacy preferences, then we need a technical policy to put in place. And we need the ability to restrict future disclosures based on those consent rules, based on sort of the security tags and granular segmentation. And all of that needs to work seamlessly together in order for the patient privacy to be preferences to be respected. And so, like I was saying, from a technical perspective, there are a handful of consent management platforms that have been developed. There are some that are open source, like SAMHSA developed what they call the consent to share, or C2S tool that was tested and piloted. There are some that have been developed that are proprietary and commercial. And there is this FHIR consent resource that a lot of work is being done to build out use cases for. IHE is working on is working on some profiles. So there's a lot of standards work and profiles being done around this. Privacy consent on FHIR profile to demonstrate consent-based access control. And I think one of the challenges that I'm trying to address is how to look at all of these pieces of really incredible and impressive work going on across the industry and frame the interrelated challenges that multiple sectors are trying to solve in more of a coordinated roadmap in order to drive success here and come up with a framework that will be viable and more widely adopted.
Yeah, I can totally relate to that challenge of bringing together disparate processes, disparate groups that are trying to solve similar or related challenges and aligning that work. So let's shift gears. Pun is intended here. You helped to co-found what's now called the Shift Task Force, which is really something that I've had the chance to work with you on a bit, where we're digging into some of these issues. Talk a little bit about the impetus to create Shift. What does the name mean, et cetera, and what are the goals of that program?
Yeah, definitely. So the goals are sort of around some of the very things that we've been talking about, and the name really means that we are shifting the paradigm, we are shifting the conversation, right? This issue of how to granularly segment data in order to protect patient privacy. It's not a new one, as you know well, Stephen. That there have been standards developed back a decade ago, but widespread adoption has been an issue. So how do we sort of shift the conversation to understand why have these not been adopted? What have been the barriers to adoption? How do we pull the industry together to understand the risks of not adopting these standards going forward from both a data segmentation and consent management perspective, and look at this through a health equity lens, right? So if we look at some of the barriers to adoption previously, one has been that previous pilots really only looked at one use case, which was around 42 CFR Part 2, legislation protecting the privacy for individuals with substance use disorder seeking treatment from certain federally funded clinics, which is a great use case to start with. And my own organization, Cambridge Health Alliance, has a 42 CFR Part 2 clinic, and this is a really important use case to start with. But there are a lot of other high priority use cases, as we've talked about, related to reproductive health, behavioral health, social determinants, shared patient records, and the standards haven't been updated yet to support these important use cases. And so, for these reasons, I think the sort of adoption has lagged because we need some solutions for these other use cases as well. Past pilots were implemented at a single site and typically not in a way that supported kind of easy scalability or the use of most of the current, use of sort of current technologies. What I mean by that is like a single pilot may have been led by a consulting company, paid by a grant. And right, if I was going to try to do this at Cambridge Health Alliance today, we would have to hire multiple consultants and sort of do this from scratch. As we were talking about, we have to prioritize our work, and we don't have the resources or the funding to do this right now. And so I think it hasn't been prioritized across the industry. And in order to do this as well, we have to define, what do we mean by sensitive data? SAMHSA developed a terminology value set back at this time, 5-10 years ago, but it really mostly supported the 42 CFR Part 2 use case. And real world testing found that there were only about 60% accuracy in that terminology value set compared with what clinicians said was accurate in sensitive data definitions. And so I think there really needs to be some semantic conceptual models to support implementation as well. And so there's also this question of, can we just have providers sitting there and tagging the data, right? I don't want my reproductive health information going to my optometrist. Well, okay, provider, are you going to just tag all reproductive health data in the record? Well, that's going to add a ton of administrative burden to providers, and then we can't have that. So how are we going to use current technologies, AI, machine learning, right, NLP to help with this, to help with security labeling of this data? And finally, the initial pilots, didn't address some of the really critical patient safety and usability issues that start to come up when you're discussing implementation, right? So as we move away from this paternalistic paradigm that we've been talking about and give competent patients the right to their own data, as 21st century cures has sort of moved us toward, is it safe and ethical for informed patients to decide to redact their data and not make it available, right? If that's the case, what does that look like to the person who was intended to receive that data? Should that data still be available for decision support algorithms? Like if I decide I don't want my antidepressant to be shared with my, again, optometrist, right? What if they prescribe something that needs to be checked in a in a drug decision support algorithm? Should that still be used? And so we haven't really been able to move this forward because a lot of those questions haven't been answered, or we haven't given guidance around those. And that's a lot of what SHIFT intends to do. SHIFT was founded very specifically as a cross-industry, cross-community collaborative to take on this challenge. We have a strategic plan and a roadmap with clear deliverables designed to get us there. As I mentioned earlier, we have a lot of different pockets of the community that we've tried to bring together, that many of whom have sort of tried individually to advance this work. And one of our high-level goals was to bring together these expert stakeholders. Now we have over 250 of them from healthcare organizations, professional societies, standards development organizations like HL7 and IHE, health IT vendors like we have Epic and Cerner, Athena Health, others at the table, HIEs and interoperability frameworks like Care Quality and Commonwealth, payers, the government, privacy law and ethics experts and patients and patient advocates, and bring everyone together to the table to work toward a solution together. So to that end, our governing board includes the American Medical Association, the American Academy of Pediatrics, the AARP, HIMSS, the HIMSS Electronic Health Record Association, IHE USA, the Drummond Group, Test Lab and Certification Body, and ONC sits on our board as well in an ex officio capacity. And so our goal is to bring together the community to solve this problem from both a technical and a non-technical perspective.
It's wonderful and very important work, and I've been impressed watching you kind of shepherd it along. Clearly, SHIFT is getting a bit more attention these days. At HIMSS, there was a really nice presentation I was able to catch, and then you had a reception of the engaged community that I couldn't make because it conflicted with something else. Tell me, how was all of that received? Do you feel that the convening that occurred there in Chicago was beneficial to the effort?
Yeah, I think it was very well received. I think we've had a number of interested stakeholders contact us at HIMSS, and afterwards we're really looking forward to having their voices at the table. I was particularly excited that we were able to demo from a technical perspective DS4P fire security labeling in the interoperability showcase. This will serve as a technical floor for our future reference implementations. We, have that technical work going on, as well as some of the more non-technical work, implementation guidance. We have a Delphi process that's moving forward to develop consensus-driven implementation guidance. And I think that is starting to take off, and we have a lot of interest in that. I think one of the reasons that it's been so well received is that we're looking at everything through an equity lens, right? We call ourselves the Independent Healthcare Task Force for Equitable Interoperability. And what do I mean by equitable interoperability? What I mean by that is if I don't have any sensitive data in my record, I get all of the benefits of all of the work that we've been doing over the past 15 years to build this interoperable ecosystem. If I show up in the ER, right? If I show up in the ER across the country, right? If I go to Palo Alto, where you are, right? And all the way across the country, my data, my problems, my meds, my allergies, even a lot of non-structured data, unstructured data now, notes and things show up because of all of this work that we've done and continue to do now through TEFCA, with Health Gorilla now as a TEFCA as a human candidate, and we're continuing to build toward these pipelines and this interoperability framework. And we've done so much, and I will get so much clinical benefit out of being able to go to the ER and my provider having all of this information, not only clinical benefit, but cost benefit as well, because I won't have tests repeated that maybe I had sometime a month ago and don't need to have repeated, and won't have those costs relate to me or to the healthcare system. But now I'm someone with sensitive data, and either I have had to turn off sharing of data of myself, and I can only right now do that at a very blunt level and turn off all data sharing, or it's done for me algorithmically by my organization in order to comply with state laws. And I either have to sign an additional consent, which maybe I don't want to do because I don't want to share all of my data for privacy reasons. I'm worried about stigma. I'm worried about legal issues now in this post-Dobbs setting, maybe if I'm crossing state lines. I'm worried about safety issues. I'm worried about data around intimate partner violence or some other issue getting in the hands of someone who could use it to hurt me, right? And so because there's not the ability to granularly segment the data, all of the data is shut off. And now I go to the emergency room, and that provider does not have that information about me. They don't know my medications. They don't know my allergies, right? And maybe they have to repeat testing. And so now I'm getting meaningfully different care. And I would say meaningfully lesser quality care than someone without sensitive data. And taking this equity lens to this issue is something that I think has really driven this forward. It has gained a lot of good reception across the community, across the industry, and especially has pushed this forward in government as well. I think people see the need to really not just keep kicking the can down the road, but address this.
Well, Hannah, I wish we had much more time to talk. We haven't even begun to talk about the work you've been doing on HITAC so far this year, and your goals for that. Maybe in the last few minutes, talk about how you see your position on the National Health IT Advisory Committee, as well as perhaps some of the task forces that we're working on together today. How do you see that as providing an opportunity to advance some of these initiatives?
Yeah, I am so grateful for the opportunity to sit on the HITAC, and I do think that serving on the HITAC is a great additional forum to help advocate for SHIP's work and to elevate privacy and equity into the national conversation. I think that I can also bring a considerable expertise to the committee in that regard. It's not the only, or perhaps even the primary reason that I accepted the appointment. I think that I can bring, a wealth of real life boots on the ground experience to our recommendations regarding policy and standards across the board. And I'm very excited to be thinking about information blocking and TEFCA and decision support interventions, all areas that we're considering as part of the HTI-1 proposed rule. I'm really excited to be able to contribute to these conversations. In particular, I think that my longstanding work with vulnerable and historically marginalized populations brings an important perspective. And I think from an equity by design lens, which is something that we're talking about a lot on the HITAC, it's really critical to have these voices at the table, both directly, and I hope that directly we'll continue to have more and more voices at the table, and in the form of advocates like myself. I think, one of my key goals is to bring forward the needs of these populations in the ways that I can, recognizing that I can only speak from my own expertise and my own experience, but can advocate to have increasingly diverse voices involved in the important work that we're doing. In terms of the HTI-1 proposed rule that we're working on, right? I'm really excited that there is a piece in this rule really looking at privacy and granular segmentation. And I think it shows that ONC is really taking privacy issues and equity issues seriously. We're obviously going to Shift is going to enter comments around this, so I can't fully speak to Shift's comments at this time while they're still in process, and you and I will be discussing further, the HITAC's comments on this. But at a high level, I'm really thrilled to see these issues incorporated, so broadly into the NPRM. Clearly, I think ONC sees the value of pushing the industry forward in this direction, and the risks to equitable patient care if we don't really thoughtfully address these concerns as we continue to build out our national interoperable pipelines. So I'm excited to have the opportunity to contribute, and I look forward to what promises to be really fruitful conversations now and in the years to come.
Well, Hannah, it's been a pleasure talking with you today, and I look forward to our additional meetings later this week to continue to dig into this. I really thank you for taking the time, and I hope that a number of people have had a chance to listen to this whole podcast, because there's a lot in here. I'm very happy we did this together. Thank you.
Me too. Thank you for the opportunity.